Okay, here we go. And I'm going to just pick up where we left off just to make sure that we got everything from this screen, because these are the basic ones you will see over and over and over of what cytotoxic anti-cancer drugs do to the body. In the bone marrow, again, they can become severely anemic to the point where they can't walk or short of breath because they have that few red cells in their body from the oxygen we know is carried in the red cells. So if those are extremely low, they reduce the number of erythrocytes, neutrophils, platelets. Loss of neutrophils and platelets is most common from chemotherapy. Erythrocytes, the red cells, not so much, except for the use of cisplatin. But believe me, we use cisplatin a lot, CISPLATIN, especially for GU type cancers, genitourinary. Anyway, so we have to be very, very cognizant of what these lab values are before we give the chemotherapy, especially if they've been on it. When a neutropenic patient develops an infection, immediate and vigorous intervention is required because they can die from an infection. And we know the neutrophils are one of the very first line of defense for infection and inflammation. And if we don't have any, then these people can get very, very ill. They can die from a pneumonia. They can die from the common cold. So a lot of times if their white counts are extremely low, they will go ahead with empiric therapy. Remember, we talked about what empiric therapy means, where they're not going to wait for the culture. They're just going to give them antibiotics until the culture gets back. Alopecia, again, is the term ALOPECIA for hair follicles, or where they lose their hair. And I'm sure all of you have seen people walking around like that. And I talked about banking the sperm for the guys. And then anti-cancer drugs can cause fetal malformation and death. They usually will not give chemotherapy to a pregnant woman. And believe me, there are pregnant women that have turned up. I mean, women with cancer have turned up pregnant. And then they have a very hard decision to make. Do I continue to carry the baby and then get the chemotherapy? Or do I go ahead and abort and have the chemotherapy? So very, very hard decisions. Okay, that's enough said about that. Does cure require 100% of cell kill? What do you think? The answer is actually yes, and that's why we're stuck right now. Because just one remaining cell can proliferate and cause a relapse. For most patients, 100% cell kill cannot be achieved. Factors that make it difficult to achieve complete cell kill include, number one, how the body affects a specific drug, which is kinetics. 2, the minimal participation of the immune system to eliminating malignant cells. That's why we are saying, where's the immune system when it comes to cancer? That's why cancer is now looked at as an autoimmune. Where is our immune system? Where are all the fighters that we learned about last week? And 3, the disappearance of symptoms before all cancer cells are gone, because they're sneaky and they hide. And finally, I wanted to let you know this. This is what is, I talk about a dilemma, is that symptoms will disappear from the cancer long before the last malignant cell has been eliminated. Once a cancer has been reduced to less than 1 billion cells, it becomes undetectable by our best, most state-of-the-art PET scans, clinical methods that we have today. So I'm going to repeat that. Once a cancer has been reduced to less than 1 billion cells, it becomes undetectable by usual clinical methods, the best CAT scans. All signs of disease is absent, and the patient is considered to be in complete remission, much like my sister right now. And of course, I have not shared this with her because everybody's celebrating, and we are much further along than we were 6 months ago with this cancer. Obviously, though, a patient harboring 1 billion malignant cells is by no means cured. So that's kind of the sad news about cancer. But let's see. When should treatment stop? When we know that 100% of cancer cells are gone, and is this possible? We're working on it. That's all I can say. Another dilemma is if therapy continues too long, the patient will be needlessly exposed to serious toxicity. Conversely, if drugs are discontinued prematurely, relapse will occur. So it's kind of everybody's individual. It's like, when do you say I can't do this anymore? Because they get very, very sick. Chemotherapy can also cause hyperuricemia, which is too much uric acid in the blood, and can result of DNA degradation secondary to massive cell death. And because uric acid crystals are very large, they can hurt our kidneys. Here it is. Renal injury can be minimized by pushing a lot of fluids. They cannot be dehydrated. Prophylactic, a drug called allopurinol, it blocks uric acid formation. So that drug's very, very important. That one you will need to know for cancer and for gout, other diseases too. But allopurinol, old drug, but very, very good and strong drug against, helps get rid of, helps actually block the uric acid formation. And then if hyperuricemia does develop despite giving all the fluids, giving allopurinol, we give a drug called rasburicase. And what that one is, most ASEs are enzymes. It's an enzyme that catalyzes uric acid degradation. So it goes in and attacks the uric acid in the blood. Anti-cancer drugs with vesicant properties can cause severe local injury if the IV line through which they're being administered becomes extravasated. And what that means, all those big words, is just if the IV comes out and the chemotherapy is going into the tissue, it can kill all of the tissue. And that's why it's called vesicant properties, severe local injury, because they are such strong drugs, and they're vile. They cause all kinds of problems. So extravasated is to force out of the vessel into the surrounding tissues. Vesicant, it causes blisters or burns to the tissue. So nurses can't even handle this stuff unless they have special gloves on. Intermittent chemotherapy is to allow normal cells to repopulate between rounds of treatment. And that's why with most people that are on chemotherapy, they'll tell you they have to go in every 3 weeks or every 6 weeks because they're so deadly. And we talked about how we're killing hair follicles. The bone marrow suppression is probably the worst, that we're hurting them. We can actually hurt their liver. We can hurt places that metabolize drugs, such as the kidney. So if the cancer cells repopulate as fast or faster than the normal cells, there will be no reduction in the tumor burden with each round of treatment. Multi-drug chemotherapy is generally much more effective. So remember that too. It's one of the areas where we give multiple drugs. We don't just give one because we don't want the people to become resistant. I mean, can you imagine if we start having resistance to the chemotherapy that we have out there? Toxicity to normal tissue is a major obstacle to successful therapy with cytotoxic anti-cancer drugs. Okay. 3 possible benefits for treatment to be justified, because it is so life-altering and life-changing, is at least one of these benefits has to happen. Cured, that's what we're all after. Palliation, meaning, again, we're trying to make them comfortable. Especially bone cancer, some really obnoxious tumors can be very, very hard to cure. And prolong life, of course, that's what we're trying to do. But I think it needs also to be, we need to look at the quality of that life. And so again, we'll go back to our cytotoxic drugs, acts directly on cancer cells and healthy cells to produce cell death. So we can't get away from that. And why does it happen on the healthy cells? Is because it's non-selective. Cell cycle phase specific drugs are effective only during a specific phase of the cell cycle. For an example, the S phase and the M phase. Accordingly, they are only active against cells that are participating in that cell cycle. Cells in the GO, remember that was the resting phase, they're not going to be effective. To be effective, phase-specific drugs must be present as neoplastic cells cycle through the phase in which the drug acts. And you can kind of see, especially with the high growth fraction drugs, they're going to want to maintain a blood level of them because they don't know when they're going through a cell cycle and they're trying to grab them and kill them. Okay, now we're going to go we looked at the cytotoxic drugs. We're going to look at the non-specific drugs. And some of these they're called alkylating agents. Family of alkylating agents are the nitrogen mustards, nitrosoureas, and other compounds. And these can act during any phase of the cell cycle, including the GO, and that's why it's considered nonspecific. So again, these alkylating agents can act during any phase of the cell cycle, including the resting, and that's why it's nonspecific. So they're almost, you can kind of look at them as they're pretty broad spectrum when it comes to killing cells. Nitrogen mustards have been around since 1942. They're very old. They're still very effective drugs. Some of these drugs can now cure cancer. High cure rate for Hodgkin's disease. They're saying Hodgkin's is almost 100% curable. It's a malignant but often curable disease of the lymphatic tissues. It's in the lymph. Hodgkin means lymph. I mean, it doesn't mean lymph. I'm sure the guy that named it, his name was Hodgkin's, but Hodgkin's is in the lymph nodes. It causes painless enlargement of the lymph nodes, and all of a sudden they're everywhere, and also painless enlargement of the liver and the spleen. Testicular cancer, acute lymphocytic leukemia, also referred to as ALL. Cell kill results primarily from alkylation of DNA. And so what is that? What's alkylation? It's a process in which one or more of the alkyl groups, ALKYL, are substituted for hydrogen atoms in an organic compound. So that's how it works. And then it says here, these agents interact with DNA by forming a covalent bond with a specific nitrogen atom in guanine. And remember guanine? We have to go back to our DNA strands. Remember guanine, adenine, cytosine, thymine are the 4 nitrogen bases that make up DNA. So it's going to go directly to that DNA strand and bust up the nitrogen atom in the guanine so that we know we need all 4 for it to replicate. So that's what these drugs do. The cell cycle is non-specific, again, can act during any phase of the cell cycle, including the GO. So very, very good cancer drugs. Alkylating agents continued, prevent DNA replication. These reactions can take place at any time during the cell cycle. I think I already said that. One of the most widely used is called cyclophosphamide, another old drug, and it's active against a broad spectrum of neoplastic diseases. So you can kind of see that it might be used with a lot of different chemotherapeutics because it is broad spectrum. And remember, it's usually a multi regime for this one. Okay, I need to end right here, and we will go on to the next one. So bear with me.